All right. Welcome back to Gaming Compute. Welcome back to the podcast. This podcast, we talk about finance overall and some side hustles. Lately, we've been talking a lot more about career-related topics, maybe shifting careers, thinking about careers. I was giving more thought to things, kind of like diving more into kind of like my emotional state and frustration with my current work situation, and was starting to realize, that I was kind of identifying more and more like what it is that is frustrating me about my work site. So in general, what I want to talk about is kind of how the healthcare system's set up, right? Like the U.S. in general, we set up a lot of our any type of company is kind of set up, not any, but a lot of companies are set up as a type of an arbitrage, right? So it's like you are getting one thing from one place and offering it at a rate where you as the company owner is making a profit. I mean, we see that's something that's like, if you take something as simple as eBay, right? And that's not really what I'm talking about here, but something as simple as like retail arbitrage through eBay, If you have a source that sells a certain type of baseball card brand cheaper than anywhere else, you basically can purchase that and sell it at a profit. Because you're competing with all the other people who sell it. You can still potentially list it lower than other people who are selling it, either on that platform, on other platforms, on all sorts of platforms, and you can list it lower than it's seen in stores, lower than it's seen anywhere else. And, a lot of times, people do that through like DHgate or other kind of like, sites in China that make a cheaper version of whatever the heck it is that you're trying to resell. And so with resell, arbitrage, usually that's how it works. The person trying to make the profit is able to identify a resource that they can get their hands on that's cheaper, so that when someone else buys it off of them at a price that's higher than they paid for it, they then make a profit. And if they're able to identify what people call like a winning product in certain niches that, a lot of people are searching for anyways, and there's already a lot of traffic being driven towards this product, people are already naturally searching for it, and you have it listed on a platform, ideally where you don't even have to, advertise necessarily, other than just posting it. People are naturally just going to search on those sites like eBay, Craigslist, whatever the heck, and purchase your stuff. And you're going to make a profit just naturally from having access to a cheaper version of it and being able to list it and sell it. And if it's in good condition and you're getting fine reviews and there's no real scammy issue with the product at all, then that's a decent business. You just happen to have access to it and you're giving them that for maybe even cheaper than they can find it elsewhere, but it's still a discount, or maybe a quicker shipping rate, or right in their local area. So maybe if it's depending on the platform, like OfferUp or something, maybe you can deliver it to them, or whatever the heck it is, if it's really something in demand. And so we see this in the healthcare system too, in a weird way. And maybe I'm not using the right word, maybe it's not called arbitrage, but I noticed this, it was kind of hitting me in my field, in psych, that this is kind of what's going on, right? The people at the top of the insurance are the ones that are saying what gets covered by the insurance, what doesn't get covered by the insurance, what a patient has to pay for out of pocket, what a person is going to get covered by connecting to this insurance that they opted into, that they qualify for, what the insurance is going to pay for, right? So the situation I'm running into is I'm getting frustrated that the insurance doesn't cover everything, right? For the people that we serve. And it's not that they're not aware that the people need these things, it's just that, it comes down to money. If they start offering this, paying for this for these clients, then that company is going to start to lose money. The insurance is going to lose money because they're paying for stuff that costs them more money than they're willing to actually spend. So I'm kind of talking in I'm kind of dancing around the main point I'm trying to make here, but I can give some more specific examples. So the clients we serve don't have money, right? That's how they qualify for their specific insurance in the first place. They get Medi-Cal because they don't make a lot of money. So that's already the major issue. And also, second to that, not only do they not make enough money, but a lot of them either are in a current position where they don't have access to, enough education or enough training to be able to get a solid paying job where they can support themselves fully at the moment. So either they're out of some kind of a recovery situation, or something as simple as they're in their 20s, they graduated college, they don't have a lot of work experience, they're making $15 an hour working at McDonald's or wherever they're working at right now, and they're not making a lot of money. Even though they're able to work a 40-hour work week, they're underpaid, especially if you think about how much San Diego costs, how much LA costs, how much Southern California costs in general. Even if they're working full time, they don't necessarily qualify for, what do you call it? The benefits, the healthcare benefits, past what Medi-Cal would offer. So they don't make a lot of money. They're not making enough money. They're not trained long enough. They haven't been working long enough to just pop into another job. Maybe they haven't fully graduated. Maybe they still owe bills, so their degree isn't posted, so they don't really have their bachelor's technically, so they can't really apply in their field. So they're stuck working at these other kind of jobs until they can get the money, until they can pay for the bill for the school, so they could release their degree, and then they could apply in their field. So it's a lot of it just boils down to money. They can't afford to pay out of pocket for breathing machines, for electric wheelchairs, for certain medications, certain types of in-home services, housing that's stable and you don't get stuck with all these weird roommate situations or unstable other people, or sharing a room as a grown adult at an ILF with people that are, maybe not emotionally fully stable, or who are triggering other people to be using substances, or who are not fully managing their own symptoms and having this stressful household environment because that's all that they can afford, even if they are working. And then we have the people who should be on disability but don't have disability either because they've been denied and their case isn't considered severe enough for them to be able to get disability, but they don't get it. Either they're in progress of trying to get it, or they don't have it yet, or they're never going to get it. But then they also aren't able to work enough to be able to support themselves fully, so they still qualify for Medi-Cal. It all boils down to money, because if they could make money, they wouldn't have to rely on the insurance to cover the stuff that they need for their physical and mental health. But they can't make the money, and the insurance doesn't provide everything that they need. Our goal at my work site is, because the insurance has identified so many people using the ERs, using the hospital systems. They're not saying don't use the ER, don't use the hospital, but from their perspective, there's an issue with the engagement of these clients in services. And on the surface, that's what it looks like. And initially, a lot of times that's what it looks like. That, we are told the people that we can connect to, that don't have a doctor, haven't seen their doctor, have been utilizing a high utilizer of ERs, hospitals, have all these unmanaged symptoms with their heart conditions, with mobility, walking issues, with pain conditions, with substance relapse issues, with not having access to psychiatric medications, with not having housing and using the shelters and then popping in and out of the hospital for stuff. Not having transportation to and from appointments, like all sorts of, this is just like classic, this is just basic stuff. I'm not even talking about the details. These are just like on the surface, when you just breeze by a spreadsheet, that's what you see on the surface. You see all these things. These are all the things that we see, that we're told the clients don't have all this stuff. They're utilizing these services only, as far as like hospitals, ERs. It's costing the insurance a lot of money. They direct us to have access to all that information, and we have the patient information, and our goal is to kind of cold call and connect to these clients to get them engaged with us, to enroll in our program, with our goal of connecting them to enough support services that they no longer are solely relying on the ER and hospitals as like urgent ways to like fix whatever the problem is at hand, right? So eventually they'd get connected to everybody, the psychiatrist, the therapist, the case management, the medical case management, the all the specialists for their heart and nephrology and all sorts of specialists, like endocrinologists, all sorts of people, pain management, pain doctors, surgeons of all kinds, neurology, they get a whole list of people that, they're able to connect with and meet with. And a lot of times, not all the time, a lot of times that helps on the surface, because now they have appointments, now they've got a lot of eyes on them. Now, a lot of the stuff on the surface that's making them come into the hospital is getting resolved. But that's not the end of the story. That's just step one. Because now that they're connected and they're engaged and they're going to their appointments, ideally, you'd want to see that they're getting better. Whatever their presenting problem is decreasing, either the physical or mental health, or the, lack of resource connection is decreasing to a point where they're now more functional than they were before, because they now have all these services, right? The discrepancy that we notice that's frustrating me, and I wasn't really able to really articulate this very well, was that what I notice is once they pass this first phase and they're connected to every single thing, what ends up happening is there's always something that it comes down to that the client needs to help them with their well-being, and stabilization to continue, that the insurance doesn't cover. There's always something that the client needs that the insurance doesn't cover, and that is creating distress with the client, and we're kind of stuck holding the bag, right? So they're connected to us. We're their go-to last line of defense person that helped connect them to all these other services, and so they assume, okay, you're so closely connected with the insurance because the insurance contracts us to work under them, more directly under the insurance. So we have access to knowledge of all the types of referrals, all the types of things we can recommend, all the stuff that they would qualify for, and it's up to the client to opt in. It's up to the doctors to fill out these authorizations or appeal for denied authorizations to get certain services. It's up to the insurance to say yes and approve it and pay for it so the client can get it. So we have things like wheelchairs that people need so that they can, get around town and go to a volunteer place, because maybe they're staying in a temporary shelter that they can only have the bed in that shelter if they are volunteering however many hours a week, and they're not able to get there because they can't walk. And the insurance doesn't cover the wheelchair. So what's going to happen if they can't pay for the wheelchair? They can't pay out of pocket. And these are the only options we have, right? Change insurance, change to a branch of something that does have access to what you're trying to get. But that might screw up some of your other services, because not all the insurance branches cover all the stuff that every single other one covers. So say you might get a wheelchair here, but now they're not covering your heart meds over here anymore, So you can only have one. You can only connect to one. So if you change insurance, if you don't do the whole due diligence process, you might be losing out on opportunities, on options. You're kind of forced to choose which is the best branch to be connected with. So that's one option. You have the other option of, have the provider, the doctor, the specialist, send an authorization over, to the insurance. If the insurance denies it because it's not covered, there's the appeal process, but eventually they say no in the appeal. And once they've appealed, they say no, there's only so many times you can appeal before it becomes apparent that they're just never going to cover the thing, right? And so instead of getting the wheelchair, for example, maybe the goal of the insurance is have them go through, 2 or 3 rounds of physical therapy to see if that works. And then we can authorize, we can approve the authorization for the wheelchair. I mean, 3 rounds of physical therapy is up to 6 sessions. That could be 2 sessions a week or 1 session a week or so. So that's for one round of 6 sessions, that's at least 3 weeks. So for 3 rounds, that's between 3 and 18 weeks. Is your temporary shelter going to let you stay in that bed if you need that much time, to not be mobile and to go through physical therapy till you can get the wheelchair, so you can get the electric wheelchair and get around town the way you need to, so you can actually find a volunteer site. So you can volunteer at a store or, a food bank or something like that, so you can volunteer somewhere. To contribute. They want the people in certain shelter programs, some of the better shelter programs, you have to be more actively involved. So in order to have maybe like a bunk bed with you and one roommate in like a house style place as a shelter versus like a shelter that's like a camp out in the middle of some lot somewhere with like a tent with like hundreds of beds where you're just like in a tent with a bunch of people like that, everyone would probably rather choose the household environment with the one other roommate and maybe 5 other rooms and there's staff who lives on site and there's a kitchen and chores and a TV and a schedule versus going into the tent shelter and then they kick you out at 5 a.m. and then you're just left to kind of like wander around until it's less comfortable. And so the less comfortable shelters don't really require you to do too much, even though it takes long to connect to anything directly. And then the more comfortable shelters have requirements. But if you have healthcare or physical or mental health needs that aren't being met by the insurance covering what you need so you can stay in the shelter, you're now at risk of losing that better shelter and you might end up on the street. So that's an option, either changing insurance or seeing if your whatever site you're connected with is going to let you stay there long enough to get through, this process to see if you can get the wheelchair by like that, I don't know how many weeks later. That's just one scenario. I mean, think about people who need like breathing tanks, or like a breathing machine, they have the mobile breathing machines with the battery versus like the one that like gives you the rolling thing where you have like the tanks on it. If you have a walker and you need the breathing machine, you need the battery if you're going to go out and walk with your walker. You can't use the handheld little carrier with the tank at the same time as you have a walker. You can't do all of that at the same time. You're already using a walker because you can't walk properly, and so to have to add an extra luggage to you, and connected to your breathing, it's like, and then they wonder, why are people missing their appointment? It's like stuff like this, where it's just like, okay, well, if the insurance would cover the battery for the mobile one, or if the insurance would do what the person needs them to do for them to function properly. I mean, those are just a couple of examples, mobility issues with like breathing devices, like it's called DME, durable medical equipment. There's a lot of durable medical equipment that's not covered by the insurance, and you think about how it's impacting a person's ability. And then another option for the client is to pay out of pocket or to ask family. A lot of them don't have stable family members that they need to be in contact with because it's toxic relationships, or people just already don't have money in the first place, and they feel like they're burdening their family members. And it's like, their family members aren't really supposed to have to be responsible for electric wheelchairs, for batteries, for breathing machines, for driving them all over the place, all over town, to and from appointments, to making sure they have access to their pain meds so that they're not using other illicit substances. All this kind of stuff, guys, all this kind of stuff. Like, it's such a frustrating situation because, I see now why it's like, this is what I spend my time doing, is trying to go back and forth between these sites, talking to this person. Can you please fax over to the insurance this information, because they need the authorization to approve, to see if they can approve it. Yes, we sent it over. Talk to the insurance. The doctor said they sent it over. The insurance states we didn't get it. Talk to the doctor again. They didn't get it. Can you please send it a second time? Yes, I'll send it a second time. They send it over to the insurance. Can you please confirm the doctor sent it a second time? Did you receive it? Yes, we received it. It's going to be however many days for us to process this paperwork, and they might not know the time frame, and then they might or might not, and then you try to get a time frame. You try to follow up within a timely manner to see, was it accepted or denied? Usually, a lot of times, it's accepted, and then we just move on. If it's not accepted, with a lot of cases, there's always going to be something that the client eventually needs, which is what we're running into nowadays, is the clients eventually find something that they need for their well-being that the doctors are recommending that the insurance won't cover. So they're asked to appeal, and then they appeal it, and then the insurance doesn't accept it. So I call the insurance and ask, okay, why wasn't it accepted? Do you need more documentation from the doctor? I'm going to call the doctor one more time and see what they need from you to see what they can do if there's like a second appeal process, if it's still denied. Usually it requires progress notes of other stuff that they've tried that didn't work properly the way the doctor thought it needed to work for the client to be more stable. And so the doctor needs to provide progress notes to prove, okay, we tried physical therapy 18 sessions later, they're still not better, so can we please approve this electric wheelchair? They provide the information. If the insurance still is declining, to pay, because it's not a qualifying type of medical equipment, and for some reason they don't consider the appeals that the doctor sent to be adequate to waive that decision, then we're just kind of left with, sorry, you can't get your wheelchair. And so the client's left to try to figure out, how do I get a wheelchair? It's either I get a wheelchair so I can get around town, I find a way to get transportation to get me to and from around town, or like better transportation, like a direct ride, which isn't usually covered by insurance. They kind of do cover some transportation, but the transportation, again, doesn't always show up, or doesn't show up on time, or doesn't follow the instructions, or shows up and then leaves. And so the clients, like 50% of the rides either don't show up to take them to the appointments, and the other 50% don't show up to take them home from the appointments. And so we're left with this frustrating situation that they don't even have basic transportation to and from appointments, let alone to do all the other errands and stuff they might need. There's no like easy solution for the transportation other than if you have a disability that a doctor can write off on and you go to the homeless support center to get what's called a handicap placard. You get the placard, and the placard qualifies you for, a bus voucher, like a public transit voucher, not free, but a reduced rate voucher. I mean, this is just so stupid. I mean, I just get frustrated with it because it's like, these are the people in our society that they cannot work. Excuse me. They cannot work. They cannot work to support themselves. So they rely on the healthcare system to be able to support them. And the healthcare system, somewhere somebody's making a decision that says we can't pay for this specific stuff. There's a list of things through Medi-Cal that Medi-Cal does not cover. Whether that's a certain, like say if somebody they notice that the medications work for them at 100 milligrams, but if they need 100 milligrams worth of it per day, but the doctor can only, and the doctor says it's fine for them to take 100 milligrams, but the insurance only pays for 20 milligrams, of the medication. And then since the doctor only pays for 20, since the insurance only pays for 20 milligrams, the client's left with the decision, okay, the doctor says I can take more, but then I'm going to run out because they can only send you a certain amount per month. So if you need 100 milligrams per day, but you're only allowed to get 20 milligrams per day, you get a 30-day supply of 20 milligrams each day versus a 30-day supply of 100 milligrams each day. If you're taking 100 milligrams each day, then after the fifth day, you're running out of medications. So then you have 25 more days that you don't have medications. So you're either asking for refills too early and then you get flagged, or, you're going back and forth with your doctors or try to see if the doctor can prescribe more. It's like, okay, well, if it doesn't work at a lower dosage and the insurance isn't willing to pay for the higher dosage, but they're willing to pay for the lower dosage, it's like, I don't know. I mean, like, what's gonna happen, Like, and I mean, I know that there are people on all sides of these arguments that say, if people can't pay for what they need, if they can't work and they can't pay, then they shouldn't have access to everything. But then it all trickles down to the other people, the tax-paying people, the other people. The system is just like so screwy, where it's like there are people at the top of these companies who are making bank because, they've decided, if we can allow for this stuff, but if we just make sure that they can't have this other stuff that's more costly, then, we're still going to make more money. That's kind of why I was mentioning at the beginning about like arbitrage. It's kind of like a weird form of it where it's like give them the least amount of services that helps the most, but still limiting the other support. So they're not fully getting all the 100% support that they need, but they're getting just enough support, but not fully all of the support that they need. And it's not a very direct method either. I mean, people like me know the system. We have worked with these systems for years, half a decade, 2 decades, 1.5 decades. Most of the people I work with have worked in this field at least 4, 5, 6, 7 years. A lot of them are near like 10 years, and we can't even find solutions, So it's like there is no solution other than the ones I mentioned, the few solutions. Change insurance branches to a branch where they have other service options, but then you might be at risk of not getting some of the stuff that you already have covered. So you might have to make that decision. Okay, maybe I don't need these meds as much as I need these other ones. Maybe I don't need that doctor that I really like that I've been seeing for the past 5 years. It really helps me out, and I'm willing to drop that doctor to have a different doctor because they offer this different type of operation that I'd like for my eyes that's covered because I need that. Or they offer this other dental service or stuff like that. And the frustration that, so there's that. There's the options of, switch insurance, find a way to pay for it out of pocket, which who knows, but sometimes clients do find some random method of, getting themselves into debt, or, a family member or some kind of church program that might pay for them or something. Like, they might find something, and that's super rare. We can't rely on them finding something like that. But when they do, we just like praise hallelujah. At least they found something, and we move on from that. It's like, okay, problem resolved. Next, what's the next problem? And yeah, so that's the option, pay, move insurances, or just go without. Just, okay, I don't need to walk and breathe at the same time, so I'll just stay at my house with my breathing tanks because I can't get around with the walker and the breathing tanks, so I'll just stay home, go without, I'm just going to completely go without. I'll just go without my meds for 25 days out of the month and have 5 good days and 25 bad ones, I'll just go without, shelter because I couldn't get a wheelchair, because, it just didn't work out. I'll just go without shelter and be on the streets until I get connected with the case management program that's eventually going to house me, because I can't stay in the better shelter because I can't do the volunteer work because I can't get around to get to and from the volunteer place. I've only mentioned a couple examples, but I'm just putting it out there because this is what it looks like. For someone in my field working with these situations, I've got 39 clients that all have situations that can't be resolved by the insurance. And still, I'm calling them all the time. I'm calling the providers all the time. I'm talking to the clients all the time. And it's like, you can kind of tell sometimes when something's just not going to work out. And then it's like, okay, at the end of the day, what do you do with that? And if you have 39 people where that's the scenario, and then we're trying to add people to our caseload and drop people who, not drop, but like we call it graduation. We graduate the people who no longer need the services, meaning we've done all we can for them. And for us to call them once or twice a month is kind of pointless at this point in time because the services don't exist that they need. And if they don't just need emotional support for the calls and check-ins, if they don't just need our emotional support, then if they don't just need our emotional support, then that's that. If they don't need our emotional support, then we'll be not needing to call them, or they might not directly tell us that they don't need our support. So then we'll be trying to call them every month, and then they're just like blocking our calls or not contacting us until they actually need something. But it's like, okay, I could have been helping other people if you didn't really want me to call you, but it's like sometimes they just want to stay on just in case they need something, even though they can re-enroll. Like, we can always graduate them, and then we can just re-enroll them if something comes up, and we can just enroll them back in the system again with us and connect them to us again. We can work with them again. That's usually not an issue, but usually they don't feel too comfortable just like actively disenrolling themselves, and so they think maybe we'll hold it against them or won't like allow them to come back in because maybe we did help them at least a little bit, and then they don't want the help. They don't want us to like completely stop calling them, but also like they don't really have like an immediate need, but they also don't want to engage. So it's like, I mean, no job is going to be perfect, but it's like at the end of the day, I see it like, I was thinking about this, and I think about this often, that I don't think I've served one client in the population that I work with. Not saying that every single person who has Medi-Cal has a history of trauma, but within the mental health system that I've worked in with clients with that qualified for the specific services of the sites I've worked at, I don't think I have had anybody on my caseload that didn't experience some form of trauma, even if they weren't formally diagnosed with PTSD or like acute stress disorder or some kind of like trauma symptom coming up, even if it's not a formal diagnosis. I don't know one person who doesn't have a history of trauma, and I don't know one person, like I haven't had one client who doesn't have a trauma history. I haven't had one client who doesn't have a history of poverty impacting them in their youth in some manner or another, whether that's their parents, grew up in poverty and just didn't know how to like talk to the client about, not, they weren't a client, but talk to my client who was their child about, the situations that were going on, or like unidentified or untreated, or unformally diagnosed, learning disabilities of certain kinds or intellectual disabilities of certain kinds, because again, maybe the parents didn't know the educational system too well to like identify and be like, yo, like my kid doesn't know how to read, or like, they have dyscalculia, or I don't know how to say it, sorry, or they have like, some other condition going on, that just isn't formally diagnosed and is getting overlooked, the schools that they went to, because they didn't have a lot of money for like living in a certain area where the schools were better, the schools just didn't really, and this is like other time periods too, when you think of it. If I have clients that are in their 50s and 60s, the school systems back then were way different than they are for like my Gen Z and millennial clients, like they're, the school systems did change since then too, and there are more, the healthcare systems have changed, and the testing systems have changed, and public school systems have changed, colleges have changed, jobs have changed, the economy has changed, like so much has changed, but I can't think of one client, honestly, of all the clients I've ever had on any of my caseloads in any sites through practicum or whatever, that didn't have a trauma history and didn't have issues related to poverty that were currently impacting their, stability in some way or another, whether that's having all these other issues with social things or whatever it is that would make it so that they didn't have the ability to work full time at a job that earned enough money so they could actually support themselves. I have not come across one on my caseload, and I think we've had some clients at the previous site where I worked at that did have money and they paid out of pocket because they liked the services. They didn't pay us, it goes through like a whole process where like the company sends the money somewhere else and all this kind of thing. Like they didn't pay us as individual therapists or group therapists or whatever we were. They didn't pay us. So that's kind of where I come from on that, is that it's just so frustrating. And, it leads me to kind of question, like, what are we doing here, guys? Like, let's be real. What are we doing here? Are we really helping the people? I get frustrated because I'm like, I don't feel like I'm helping anyone. Yeah, I help them on the surface at the beginning, at the start, but that's not good enough, because we're always bumping up against these walls where I feel like we get to these situations with the medical equipment or the medications or the services that they don't qualify for, or the shelter programs being like so swamped that they can't even house people, it's like, or remember to like call the clients back to like help them on time, and so I feel the way it feels is like there's a brick wall and I'm there with a little baby pickaxe, like picking at the wall, trying to find like a solution to get through the little wall. And then there's people in the insurance that are just rapidly building this wall out and patching up the wall as quickly as they can and blocking us from, getting through the wall. And it's like, I feel beat down by the system, and I'm working to try to penetrate this system. And on the surface, it almost looks like to our clients that we are the system because we're so closely connected to the insurance, because our direct contract is with them, and we directly talk to the insurance branches. We directly report from the insurance branches. I get direct emails from the insurance branches, about like hospitalizations and stuff like that. Like, they directly contact me. They tell us right away. So, yeah, that's kind of, I have the options too. So I have the options on my end. Leave the job because it's frustrating, because I just don't like that role. I don't like the role of being part of a broken system. I have the option of stay at the job and do what I can to just maybe not, definitely not burning the bridges and like being loud and like, just fight the system, kind of like use, so much assertive force that I'm like making problems. But I do believe in helping these populations of people who can't work to support themselves because of the life that they've had to endure with all the situations they've had to go through. That's how I see it. The people that we work with them so tightly. Our clients, we work with them so tightly that I feel like if they could work, they wouldn't be enduring things the way that they are. If they could work, they would work. If they could get more money to not have to deal with all the stressors and risks that they're exposed to just from not having money. I mean, all it takes is like one landlord in an affordable housing program to be like, oh, you have a roach infestation. Sorry, you're going to have to vacate the premises and move, and then what? The housing voucher that they have covers that direct site. And so then what? So, I have the option to leave. I'm still strongly considering that. I don't really want to backpedal too much, because it's like, how much do I need to really be wearing myself down in my young life, to be, helping a system that doesn't want to help its own people, because there's somebody at the top. There's a lot of somebodies at the top of these programs that aren't doing it. I have options of learning all that I can and then creating my own system, my own program that works better. That's one option. I have the option of, I'm trying to go these other indirect routes right now of learning about some of the mental health apps that are coming out and figuring out how to, get into making those apps that contract with the insurance and stuff like that. Like having my own direct service that I create as something that people can be referred to, but that's not resolving all the major issues of like the stuff that the insurance doesn't cover. It's just offering another option. I could probably make one option that gets covered. I don't think I could make an option that would cover all the possible things that the insurance doesn't pay for. But that would be the option, is to find a way to make like a service, or if there is a way to make multiple services that are free and actually help people in the holes that I'm seeing. I don't know what that would take. Like, that's, how do you even like develop that? Like, that just is a lot. Like I know like on a small level about grant proposals and that kind of thing, but if I'm gonna stay in this field, something's got to give. I can't really stay at this job as is. with the barriers that we face as staff, as well as the low pay, I've got to get out of this job as it is. So I can't stay, at the very least, because of the pay rate. I can't stay at this point, because at the moment it's my main income source for the most part, because I'm pretty swamped lately, and I just don't have so much extra energy to be contributing towards other projects right now. Like, I do these projects, this the podcasting projects and things like that, and they can bring in some money, but I'm still kind of figuring it out too, with Anchor and everything. Like, I'm more familiar with with blogging and SEO through WordPress sites, and even YouTube, before they changed it so that you couldn't just easily monetize with a lower amount of subscribers. I was definitely more used to YouTube, because I was interested in tech repair, just home repairs for software and tech problems with certain popular gaming laptops and stuff like that. Not that they all had problems, but I was very familiar with the products I used, and I was able to identify some of the problems that the machinery had. So yeah, I had a really this has just been a frustrating experience lately. I don't know how it crept up on me, but I'm taking you guys through my journey with this, and I'm not only going to be posting venting content about me, complaining about my job and stuff, but it's you can probably tell, I care about what I do. I'm not just fuck it, I hate these people, I'm out, bye. It's I don't hate the people I work with. I love the people I work with. I don't hate my clients. I love the clients. I love the field of psychology. I love, the kind of work that we can do that's, possible for us to execute, that we're able to kind of do. I don't like all the stuff that we're not allowed to do or not able to do, and all the underpaid issues too. That's a whole other issue of its own. The contracts are too limited. So we're constantly going to be forced to be bouncing through jobs. If the economy keeps changing, I went from my first job site where it was low pay, but I kind of didn't care because I loved it so much, but I knew I couldn't stay there forever. And then I got into this site, which paid more than most of the other sites because their contracts were older and ours was newer, but now our contract hasn't changed with all the other contracts that have changed. So the pay is now less competitive where I'm at now, and even the previous site I was at now pays significantly more, almost between $5 and $10 more an hour than what I'm already getting paid for the same job I just did. If I was still there, I would have been getting paid now. I would have been getting paid between 12 and 7, between 12 and, sorry, I can't do math right now. I'm really tired. Between 12 and $17 more an hour than what I was making 2 years ago. Or a little, 2.5 years ago. $12 to $17 an hour more for the same job. Different climate, different staff there now, and some things have probably changed a little bit, but same job description, same job I did for 5 years, pays $12 to $17 more now. All of a sudden, as of July of 2022, they pay more now. And less than what I currently get paid. And so it's decisions like that. And it's okay, I could bounce back to that company and get back into that job and be getting paid more, in a way, but then I'd still be losing money on, transportation. I'd have a higher stressed job, faster pace, more crisis management, more severity, of like immediate like crisis, immediate severity of symptoms right in front of my face. That's a lot more exposure. I mean, it's something that takes its toll on me too, to have to deal with that. And so it's like, yeah, I get paid more, but deal with that, So that's where my head's at. That's where my heart's at. And so with that, it's kind of all I have to really say, but thanks for listening.